This is Stephanie Huff. I'm recording the Perfusion lecture. This is the peripheral vascular disease section of that. Just an overview. Peripheral vascular diseases are conditions that do affect the peripheral arteries and the veins. This is done by impairing the blood supply to the peripheral tissues, particularly to the lower extremities. Arteriosclerosis is characterized by a thickening, loss of elasticity, and calcification of the arterial walls. This is the most common cause of chronic arterial disorders. Atherosclerosis is a form of arteriosclerosis in which deposits of fat and fibrin will obstruct and harden the arteries. This is in the peripheral circulation, not in the central that we're talking about in this aspect. And it will impair blood supply to the peripheral tissues, particularly in the lower extremities. And this is known as peripheral vascular disease or peripheral artery disease. Chronic venous insufficiency is a disorder of inadequate venous return over a long period of time. It is a long-term condition that occurs because of a vein blockage or valve leakage in the legs, making it difficult for the blood to return to the heart from the legs. So the blood pools, causing stasis, and DVT is the most common cause of chronic venous insufficiency. Alright, so this is showing plaque in the artery, and this is known as atherosclerosis. And then you can see the chronic venous insufficiency in the lower right picture, and the valves don't close properly, so this allows that blood to leak. And so this is just a picture of that blood leaking back in. Alright, so I'm looking at some pathophysiology. Atherosclerotic lesions will obstruct the vessel lumen. In this, the atherosclerotic lesions involve both the intima and medial of the arteries. Thrombosis occurs in lower extremities more often than in the upper extremities. The plaque usually forms at arterial bifurcations, and that's where the vessels come together and meet. This will progressively cause obstruction of the vessel lumen. Thus, they will have a decreased blood flow to the extremities. Hypoxia or anoxia will result from this. Hypoxia is just low oxygen, and anoxia is without any oxygen at all. Then collateral circulation will develop, but it's usually inadequate to meet the tissue needs. Manifestations develop when about 60% or greater of the vessel is occluded. Chronic venous insufficiency results when venous blood collects and stagnates in the lower extremities. This is also known as venous stasis. Venous pressures in the calf and lower leg will increase, especially during ambulation. The pressure increases. This causes an impairment in arterial circulation as well. Oxygen and nutrients are unable to get to the lower extremities very well, so the cells will begin to die. The skin will start to atrophy, and so the fat deposits will also start necrosing. You will have red blood cell breakdown in these congested tissues, and this will cause the skin to turn and have a brown pigmentation to it. The venous stasis ulcers will start to develop as the conditions worsen over time, and then the ulcers will begin to enlarge. Now looking at etiology, This is for your peripheral vascular disease. It affects individuals in their 60s and 70s. It used to be that men were affected more than women, and now it's about equal between men and women. Blacks tend to have a higher rate than Hispanics or whites, but Hispanics have a higher rate of peripheral artery disease than non-Hispanic whites do. Some of your risk factors, these are going to be similar to those for coronary heart disease and atherosclerosis. So it's going to be diabetes, hypercholesterolemia, hypertension, smoking, physical inactivity, being overweight. Can also be from family history of vascular disease. Clients over the age of 50 are also at risk. Alright, and so this is just showing a difference between arterial versus venous. And so you can see on here for arterial, it is an insufficient blood supply to the area that causes ischemia, which is tissue death. Venous is pooling of the blood in those lower extremities that causes that increased pressure in those veins. So you can see risk factors for both and then characteristics for both. And this is looking at the ulcerations that are caused with venous versus arterial. So on arterial, it has that punched out appearance, and so you can see how the edges are well defined, but on the venous side that they're not, and they're a little bit more shallow and superficial. For your arterial, a lot of times they have pain at night, and pain is often relieved by elevating the leg. It hurts worse usually in the dependent position. A lot of times these lesions will occur on the lateral foot, but they can occur anywhere on the lower legs. A lot of times you'll see them on the toes as well. Lower extremities are cool to touch. They're pale, shiny. Skin is thin, minimal to no hair growth, and minimal drainage from the wound. On your venous side, these are usually associated with painful edema, phlebitis, and infection. It's usually in the lower legs or ankles is where these will occur. So pain is your primary symptom of peripheral atherosclerosis. Intermittent claudication is a cramping or aching pain in the calves of the legs and thighs. Sometimes it actually goes up into the buttocks, that occurs with a predictable level of activity. It is characteristic of peripheral vascular disease. Pain often is accompanied by weakness and is relieved by rest. So usually they start walking and then they'll have this pain, but then as soon as they rest, the pain goes away. Your rest pain occurs during periods of inactivity. It is described as a burning sensation of the lower legs. Pain will increase when the legs are elevated and decrease when the legs are in a dependent state. So example, like having the legs hanging over the side of the bed will decrease their pain. The legs may also feel cold or numb. Sensation is diminished and the muscles may also atrophy. Peripheral pulses can be decreased or absent. Sometimes you can hear a bruit over large arteries, and usually this is in the femoral abdomen and the aorta, and that's just because that blood is rushing over a narrowed vessel lumen. The legs tend to be thin. The skin is thin, shiny, hairless, with the discolored areas. A lot of times they'll have thickened toenails, areas of skin breakdown and ulceration. Edema may develop with severe peripheral vascular disease. A lot of times the legs are have a pale color when they're elevated and they become dark red when they're dependent. It's also called dependent rubor, and rubor is R-U-B-O-R, and that's another name for that red color. Your chronic venous insufficiency has some other different manifestations, and that is lower leg edema that worsens when standing. They may have itching, dull discomfort or pain that increases with prolonged standing. Their skin is thin, shiny, and it starts to atrophy. It can be also cyanotic or brown in color, and that's usually on the lower legs and foot. They may also have possible weeping dermatitis. A lot of times they have thick fibrous, which is just hard subcutaneous tissue with recurrent ulcerations of the medial or anterior ankle. And the extremity a lot of times will develop that cyanotic appearance. Alright, and then this is just a picture showing you venous versus arterial disease, and looking at the blood flow and causes of your different disease process. Alright, and here again is just another slide showing you arterial insufficiency versus venous insufficiency, and it's got some of your clinical symptoms. And so this is really important to be able to know the difference between arterial versus venous. Alright, and so this is just another table that is just kind of going over your arterial disease versus venous disease. And so you can see here it's looking at the skin, type of pain they may have, the ulcers, what they look like. Your venous disease is also your chronic venous insufficiency. So that's your CVI that you'll that we've been talking about as well. Looks at the pulses and then swelling. Alright, and so these are some different pictures. On the medial ankle, both of the ones on the left side of your screen, these are venous ulcers. The ones on the bottom of the foot, the toes, and the base of the great toe, those are all arterial ulcers. And you can see on those how they have that sort of that punched out appearance on those, and the venous ones have a more irregular and more shallow appearance to them. Alright, looking at collaboration, management of peripheral vascular disease, they will have frequent, need to elevate their legs and feet frequently. This will help reduce edema. Bony prominences need to be well padded when wearing semi-rigid boots when they're treating the ulcers, so make sure that they have good padding. Avoid prolonged sitting or standing. You want to treat associated symptoms. A lot of times they have difficulty with treatments for ulcerations, your stasis dermatitis, weeping dermatitis. A lot of times those are more difficult to treat. Your diagnostic test, there's nothing specific for chronic venous insufficiency, so these are things that they'll do for the peripheral vascular disease. Your segmental pressure measurements uses blood pressure cuff and Doppler device to compare blood pressures between the upper and lower extremities. Normally they should be similar. In peripheral vascular disease, the blood pressure may be lower in the legs than it is in the arms. Stress testing, this is a treadmill type stress test that provides functional assessments of limitations. So in peripheral vascular disease, pressure at the ankle may decline even further with exercise, and that helps confirm that diagnosis. Your Doppler ultrasound, that's just evaluating the blood flow. In peripheral vascular disease, it shows obstruction and the location of this obstruction. Again, on the collaboration, that's going to focus on relieving symptoms, promoting circulation, healing, and preventing tissue damage. All right, other diagnostic test, a duplex Doppler ultrasound. We've talked about this previously, but this uses audible or graphic Doppler ultrasound to identify venous or arterial abnormalities. Your transcutaneous oximetry evaluates the oxygenation of the tissues. Your angiography and MRI, these are done before revascularization procedures to locate and evaluate the extent of arterial obstruction. So pharmacologic therapy, your aspirin and clopidogrel, which is your Plavix, those are help to inhibit platelet aggregation. Your silestazol, that's also Pletal, is Pletal, and that's a platelet inhibitor with vasodilator properties, so that will increase blood flow to the extremities, thus improving claudication. All right, your pentazephalin is also Trental, that decreases blood viscosity, so it makes it not as thick, and it increases the red blood cell flexibility. So in turn, this will increase blood flow to the microcirculation tissues of the extremities. Drug treatment for peripheral atherosclerosis is less effective than that for coronary heart disease. So it works better for coronary heart disease basically than it does for peripheral atherosclerosis. All right, some of your non-pharmacologic therapy. Smoking cessation is going to be vital in the treatment of peripheral vascular disease. Nicotine promotes atherosclerosis, causes vasospasms, which further decreases blood flow to the lower extremities. They are going to need meticulous foot care. This is going to be very important in preventing ulcerations and infections. Providing pain relief. One thing that they can do is increase the head of the bed on blocks at home, and that will a lot of times help relieve that rest pain. If they do have that intermittent claudication, they're taught to rest at the onset of that claudication and resume activity when the pain subsides. Your elastic support hose reduces circulation to the skin, and so these are often avoided. They need regular progressive exercise, 30 to 45 minutes of walking a day. This is going to be important. Other measures to slow atherosclerosis process is done by controlling their chronic diseases, diabetes, helping to lower those cholesterol levels, treating and controlling hypertension, doing weight loss. All of these are going to be recommended therapies. Surgery, revascularization. Surgery is done if symptoms are progressive, severe, or disabling, or if the symptoms interfere with their activities of daily living, rest pain, or if they have pre-gangrenous or gangrenous lesions. Because that just means that the whole tissue is dead and it's not coming back from that, so they have to remove that to keep it from spreading. Your percutaneous transluminal angioplasty, stent placement, and arthrectomy, these are all non-surgical procedures that can also be done. They are invasive, they're just not surgical. Usually these are done like in the cath lab. Your surgical procedures, your endarterectomy, that will remove occlusive plaques from the arteries. Your bypass grafts are used to bypass the occlusive sites. For those non-surgical procedures, these are all just techniques that can include like balloon angioplasty to help dilate narrow lumens. Your mechanical arthrectomy is done to remove plaque. There's also laser and thermal angioplasty, and that is used to vaporize the occluding material. But basically, in any of these cases, usually a stent is placed at the time that the angioplasty was done to help maintain that vessel patency. Some of your complementary therapy, this includes interventions to help improve peripheral circulation and help reduce stress. So you've got aromatherapy, biofeedback, healing or therapeutic touch, massage, herbal therapy. This is things like ginkgo, garlic, cayenne, hawthorn, bilberry. Exercise and yoga is also used to reduce atherosclerosis and help lower cholesterols. They will work with their diet and antioxidants, so they need to be on a very low fat or vegetarian diet. A lot of times they will include antioxidants, which are nutrients. They will also use vitamin C, vitamin E, or garlic supplements. Also, traditional Chinese medicine may be helpful. Looking at education, they need to elevate the legs at rest and sleep. Walk as much as possible, but avoid sitting and standing for prolonged periods of time. Avoid crossing the legs when sitting, or allow pressure on the back of their knees, like sitting on the side of the bed, because that is all going to cause decreased blood flow to the lower extremities. Avoiding tight-fitting garments or anything that pinches the legs, like knee-high hose, garters, or girdles. And especially you'll see some of your elderly women that still wear girdles. Wear elastic hose as prescribed. It should be tighter over the feet than the top of the legs, but you want to make sure that it doesn't cut into the leg at the top. And so that's going to be dependent on exactly what's going on, because a lot of times if they do have those ulcerations and lesions, then they may not be wearing those elastic hose because of the skin damage that's already there. You want to demonstrate good foot care. Need the skin to be on the legs and feet to be kept clean, dry, and soft. There's a good box on page 1202 that has all of the teaching for foot and leg care for patients that would be helpful for you to review. All right, looking at the assessment, you want to get a good health history. And so this is going to be, do they have any history of coronary heart disease, peripheral vascular disease, increased cholesterol, hypertension, diabetes. You also want to know about what current medications they're on, their smoking history, their usual activity patterns, and what their usual diet consists of. When they're complaining of pain, you want to know about the relationship to exercise or rest, because that's going to tell you a lot about if it's rest pain or intermittent claudication. You also want to know the timing of the pain, any associated symptoms, and what the relief measures are. So basically what makes it worse, what makes it better. Physical exam, you want to make sure that you're including your full set of vital signs. Peripheral pulses need to be assessed for strength and quality. You also want to assess capillary refill, the temperature of the skin in different areas of the body, including the extremities. You also want to look at hair distribution over the extremities. Also look at skin color and presence of any discolorations or lesions. You also want to note movement and sensation of the lower extremities. These are your diagnoses for peripheral vascular disease. And of course, as always, we will go through these. And then these are your nursing diagnosis for chronic venous insufficiency. And so you can see how they can be similar but also be different. So planning, these are your goals. You want the patient to stop smoking, be able to learn more about foot and wound care, maintain compliance with their medications and their wound care, and then maintain activity and exercise as tolerated. So implementation and promoting tissue perfusion. Nursing care for your patient with chronic venous insufficiency will focus on improving tissue perfusion and preventing tissue damage as well. But they both, peripheral vascular disease and chronic venous insufficiency, both need tissue perfusion promotion. So assessing peripheral pulses, you want to position with the extremities dependent. Gravity promotes arterial flow and increases tissue perfusion and helps to relieve the pain. That's going to be important with your chronic venous insufficiency. You want to discuss regular exercise and the benefits of it. It does promote the development of collateral circulation to those ischemic tissues. It also slows atherosclerosis development. You want to support the extremities with a foot cradle, which basically protects the tissues from compression of the linen. You also want to make sure that you keep the extremities warm. So lightweight blankets, socks, slippers can be used to help with warmth. You want to avoid avoid electric heating pads or hot water bottles because a lot of times they have that decreased sensation, and so they could actually develop second and third degree burns from those. Keeping the extremities warm conserves heat. It promotes vasospasm and promotes arterial flow. Alright, you want to encourage frequent position changes. This promotes blood flow and reduces damage caused by pressure. And again, avoid leg crossing or pillows under the knees because that will partially obstruct the arteries. In addition to checking those peripheral pulses, making sure that you're assessing their pain, the color of the extremities, temperature, capillary refill. This is done at least every 4 hours and as needed. If you are not able to palpate a pulse, you have to Doppler it and mark it with an X so that everybody knows where the pulse is should be located, and that way if they can't find it, then we know that we've had a change in their status. Alright, managing their pain, you want to assess at least every 4 hours. Most often it's at least every 2. You should use the standardized pain scale, but remember, pain is subjective. Keep extremities warm. This causes vasodilation, which improves arterial blood flow. You want to teach pain relief and stress relief strategies. This can be done through relaxation, meditation, guided imagery. Pain, if your patient is in pain, this increases their stress level. And then once they're stressed, this causes vasoconstriction, which in turn increases their pain. So it's just kind of like this vicious cycle. So we just want to make sure that we're treating both of those. Promoting skin integrity, provide meticulous skin care daily, keeping the skin clean and dry. Moisturizing creams should be done to dry and scaly areas. You want to apply a bed cradle, and this basically suspends the bed linens over the legs, preventing pressure on the extremities and the injured tissues. So it prevents further skin breakdown. Providing egg crate mattresses, flotation pads, sheepskin, or heel protectors. These will also help to prevent damage to those ischemic skin areas. Alright, encouraging activity. You want to assist with care as needed. This is going to be particularly important for rest pain and claudication may limit their activity. Muscle atrophy is common, and that leads to fatigue and weakness as well. Unless it's contraindicated, you want to encourage a gradual increase in activity. This is also looking at the duration and intensity. So maybe they can't walk as far or as fast at first, but they should be able to build on that. And so this goes with activities and different types of exercise. Providing diversional activities. This is really important during periods of bed rest, during acute episodes, and this will prevent boredom and stress. So again, relaxation, different things to help reduce muscle tension. You also want to encourage frequent position changes and active range of motion exercises. Encourage self-care to the extent possible. This helps them feel included in their plan of care, and it also helps with active range of motion. All right, looking at the evaluation, expected outcomes can include client being able to demonstrate positioning to promote perfusion of extremities. They should also be able to demonstrate abstinence from tobacco products, and so that may be beginning a smoking cessation program. Clients should be able to verbalize the appropriate wound care, and they should also be able to verbalize signs and symptoms of infection to report to their healthcare provider. So that's the end of peripheral vascular disease. So I know that's a lot of stuff for perfusion, but that kind of gets everything that you need to know as far as the concept and the stuff we talked about in class and then the rest of this. So again, if there's any questions, please let me know, and I will try to clarify anything that you have questions about.